madam. We are happy to have you here to discuss about difficult pain. And I hope you have a few sessions on pain management. And today, our topic of discussion is difficult pain. And we have Dr. Mary Abraham. You all know about madam, and you had a previous session about pain management taken by Dr. Mary Abraham. Today, again, she is joining with us. Uh, it's our pleasure to have you here for discussing this topic, madam. Over to you, madam.
Okay, am I audible?
You are audible.
Okay, thank you, Grishma. Thank you, Shri Priya. And I will, last time I had talked about step 1 and 2 drugs, along with the drugs for neuropathic pain and adjuvant drugs. So today we will just shift into a higher gear and move into the approach of how you manage a patient with difficult pain. Because sometime or the other, we do come across patients with difficult pain in our practice. Okay, and it is quite difficult, but we need to have at least certain principles in mind when we come across these people. So this, like I told you, was the step 3, 1, 2, and 3 of the analgesic ladder. And when you reach step 3, that we give for severe pain, we give strong opioids. But like I told, with this, we managed to treat only about 75% of patients with pain. And there is a segment of patients, it may be small, maybe 10 to 15%, but who will not even respond to strong opioids. So how do you handle them? Like I said, this is the one that is called refractory pain or difficult pain. So the other terminologies are persistent pain or opioid non-responsive pain. And if you look at the definition, it is pain related to cancer or its treatment of at least 3 months or more duration that has not responded to standard treatment with opioids and co-analgesics. Now, there are certain patients who are susceptible to get intractable cancer pain. Who are they? Young people. They are more susceptible to get refractory pain. Patients who have neuropathic pain are more difficult to treat. Incident pain. Continuous pain is easier to treat, but when there's incident pain, that is pain on movement or pain on any activity, that makes it a little difficult. When there's a superadded psychological distress, when there's a history of previous opioid use, they may be tolerant to the use of strong opioids, or if there's a history of addiction, or if there's impaired cognition. Okay, these are the risk factors for patients to have intractable pain. So let me start off with a case scenario. This is a patient who's a 62-year-old man with a CA rectum. He had peritoneal and liver metastasis, and he was on chemotherapy since 1 year. He developed acute intestinal obstruction with pain in the abdomen due to progression of the primary lesion. Because of that acute intestinal obstruction, he was taken to the emergency room and admitted for conservative management of intestinal obstruction. A Ryle's tube was inserted and a colostomy was done. And after stabilizing him with fluids and antibiotics, he was discharged with the advice of continuing with palliative care treatment at home. So initially, he was taking WHO step 1 and 2 drugs through the nasogastric tube along with adjuvants for pain abdomen. But the abdominal pain persisted and he had to be started on step 3 drugs orally through the Ryle's tube. But one day, he pulled out his Ryle's tube and he categorically stated that he did not want it reinserted. In the beginning itself, he was objecting to the Ryle's tube, and now he was certainly not amenable to having another Ryle's tube again. So there was a family discussion, and we wanted to discuss how do we feed him now that his Ryle's tube is out, and how do we give him his analgesic drugs, because he had become extremely weak and emaciated. But keeping the patient wishes in mind, that is the patient autonomy, we decided not to reinsert the Riles tube. And we started him on IV fluids through chemo board. But the pain grew worse and he had to be started on transdermal fentanyl patch, 25 mics per hour, with oral transmucil fentanyl citrate, that is a OTFC, that is a fentanyl lollipop, which had a strength of 200 mics, and that we were giving it SOS. But there was no relief in pain, and he was in agonizing pain, and he was crying and shouting in pain, and the family became extremely distressed. So how do we handle this scenario? So we'll come to this at the end of our presentation. So when you encounter a patient with difficult pain, there are a few steps that we need to keep in mind. First is we need to review the whole case, including the disease, whether there are superadded psychosocial factors, whether there is any adjuvant pain, so many things. We need to review it. We need to once again do a comprehensive pain assessment. And then we need to manage either with pharmacological or with non-pharmacological modalities. So these are some of the pharmacological modalities, and these are some of the non-pharmacological modalities, but I will talk about it later on in my presentation. So when you want to review, we can keep the mnemonic A, B, C, or double C in mind. A, is the patient adhering to the treatment? So we have to check about whether he's actually taking all the medications as you advised. The B is you have to believe the patient that he has pain. Like Margot McCaffrey in 1968 famously said that pain is whatever the experiencing patient says is existing, whenever he or she says it does. Or in simple terms, pain is what the patient says hurts. After that, we need to, I said, do a comprehensive pain assessment in which you go through the pain characteristics, the functional history. Functional history is pain with any activities. Okay, is he able to do his daily functions? Then we need to review the previous drug history and also the non-drug history, like the psychosocial factors and other factors that are playing a part. We need to examine him, and then we need to review everything together. And the last C is to correct the correctable factors. There could be a superadded problem like a pleural effusion or an ascites, which can be contributing to the pain that needs to be tapped. There could be an underlying superadded infection. There could be insomnia and anxiety. Remember, this insomnia and anxiety are actually opening the gate for the pain. So it actually enhances the pain the patient is feeling. His nutritional status, etc. So we need to correct the correctable factors. So when we look at adherence to treatment, we need to review the analgesics, review the adjuvants. Is he getting all the adjuvants that is necessary for his pain? We need to check the patient's understanding of the dosing regime. So when you have a prescription like this, we have to make sure that the patient is taking as per your prescription. For example, paracetamol is 3 times a day. Is he taking it according to that, or is he taking it only when the pain comes back? What about morphine? Is he taking that meticulously every 4 hours with the SOS doses like you told him to take for breakthrough pain? And what about the constipation drugs? So you have to do what is called a teach back technique. You ask the patient or the attendant to read everything and see whether they are taking exactly like you have prescribed. So that way we can ensure that they are adhering to the treatment. Now, some of the reasons for opioid ineffectiveness, like you're giving the strong opioids, but it is not acting. So what are the common reasons for opioid ineffectiveness? One is the accumulation of toxic metabolites. Okay. That will cause a hurdle for you to escalate the dose. Or is there a progression of the disease? That is a very common reason for intractable pain. Or is there a new pain type? Is there a neuropathic pain, a new onset bowel obstruction, like in this patient I discussed now? Or is there spasticity, which is contributing to pain, or muscle spasm? Or if there is insomnia, anxiety? So you have to see the various causes that can be contributing to the new pain type. Or is there intolerable side effects? Like I said, when there's an accumulation of toxic metabolites in case of morphine, you can get neurotoxicity. And that itself will prevent you from escalating the dose of morphine. Or is the route of administration that you're giving not effective? Or that is called a failed route. For example, is there a poor oral absorption? In intestinal obstruction, there could be a failure in absorption of the drug. Or if you're giving a patch, is there a diminished transdermal skin absorption? Or is there a system malfunction, like a pump that's not working, or a needle that is blocked, or a catheter malfunction? And this can happen with intravenous, subcutaneous, or even spinal drugs that you're giving for pain. And not to exclude the psychological, social, and spiritual factors that are adding to the cause of the pain. So like I mentioned, you have both pharmacological and non-pharmacological methods of treatment. So coming to the pharmacological options, first of all is opioid manipulation, in which you can either convert the route, which is called route conversion, or you can switch the opioid, which is called opioid rotation. Or you may need to add an adjuvant drug. And there are a whole lot of adjuvant drugs that may need to be added to treat this kind of pain. Now, coming to the parenteral opioids that we are giving, we may need to do what is called a route conversion, in which you're giving the same opioid, but in a different route of administration. For example, you are so far giving oral morphine and it is not working, you may have to switch to IV morphine. Or you're giving a transdermal fentanyl patch, but like in this patient, it is not working, and the patient is still having pain, you may have to switch over to IV or subcutaneous fentanyl. Now, high serum concentrations has been shown to be achieved by both intravenous and the subcutaneous route of whichever analgesic you're giving, whether it's morphine or whether it's fentanyl. And they both can be given in both routes. Just remember the conversion factor of oral to subcutaneous to intravenous morphine is 3:2:1. For example, you're giving 30 mg oral morphine, then subcutaneous dose is 20 milligram and intravenous route is 10 milligrams. So this intravenous opioids that you're giving for difficult pain can be given as a continuous infusion through a syringe pump for continuous pain. But if there is an incident or breakthrough pain, the patient may need, over and above that, an intermittent bolus. So in patient-controlled analgesia, you can treat both continuous and incident pain. There is a pump that is here, and there is also a remote. So the remote will give you the intermittent dose. And the patient can self-administer it herself or himself. So there's basically a continuous basal dose, which you calculate according to the requirement of the patient. And then you calculate the bolus dose, and that is used for treating the breakthrough pain. So these are the disposable pumps, that is elastomeric pumps that are available. And also you have the CADD pump, or the continuous ambulatory drug delivery pump, which is not disposable, but the drug is added into a chamber into this. And this also has a remote in addition. Now, if you look at oral versus subcutaneous, there is no evidence of the superiority of parenteral versus oral opioids. But yet, the European Association of Palliative Care recommends the use of parenteral opioid infusions in cases where oral or transdermal opioids are not effective. Now, we talked about opioid conversion. Now we look into opioid rotation. So opioid rotation, or what is called a switch, is you give the same different opioid through the same route. For example, oral morphine can be converted into oral methadone. The indications of opioid rotation are either intolerable side effects due to neurotoxicity or poor analgesia despite titration of the oral drug that you're giving. How does it work? It works by what is called incomplete cross tolerance. Normally, cross tolerance is when a patient is given a particular drug and the tolerance develops. Because the receptors are the same, there could be possible tolerance with other opioids. But this cross tolerance is incomplete. So there are still some receptors that can work with that can attach to the newer opioid that you're giving. And that is how opioid rotation helps in managing pain due to tolerance of a particular drug. So you can even get greater than anticipated potency with another drug, another opioid. But when you convert from one opioid to another, there are 3 steps to keep in mind. Is first of all, you look up the equianalgesic table to find out the equianalgesic dose, or what is called the oral opioid equivalent. For example, when you're giving 60 milligrams morphine, that is equivalent to 25 mics per hour fentanyl. That is the equianalgesic dose. But after you calculate the dose, because of the cross tolerance that may be there, you may have to reduce the dose by 50% in patients with well-controlled pain, and those with poorly controlled pain, you reduce it only by 25%. The exception is methadone. I'll talk about it later. And then you need to prescribe a rescue dose as well. Now, what are the side effects of morphine? So this is sedation, delirium, myoclonus, hallucinations, hyperalgesia, seizures. So these are the neurotoxicity side effects of morphine, which we have to look out for. And the cause of it is because of its metabolites, that is morphine 3-glucuronide and normeperidine. These are the ones that are causing the neurotoxic side effects of morphine. So when you're rotating opioids, in India, we only have 2 other alternatives. One is methadone and one is fentanyl. That is among the strong opioids. Drugs like oxycodone and hydromorphone, etc., are not available in India. Now, methadone is inexpensive and it can be given orally, but all of them are under the same legal control as morphine. So if you look at methadone, what is its advantage? It has got a high potency. It is effective for neuropathic pain because it can block the NMDA receptor, and also it is a serotonin norepinephrine receptor inhibitor. And that is why methadone has the added advantage that it is good for neuropathic pain. Now, this is not a prodrug. Unlike morphine, it has no known active metabolites. It has a relatively long half-life of 8 to 12 hours, so you don't have to give it as often as you give morphine. It is slowly eliminated, and so there's a less risk of breakthrough pain, which can happen with morphine, which has a shorter duration of action. It does not accumulate in renal impairment and can be given in patients with renal dysfunction. There is less tendency for tolerance and no cross tolerance, and it is also relatively inexpensive. But it has got certain disadvantages. One is there is a risk of life-threatening ventricular arrhythmia, particularly if there is a QTC prolongation on the ECG. That can lead to a life-threatening arrhythmia called torsades de pontis, which is a ventricular arrhythmia, which is very difficult to treat also. And also, the titration of this drug is relatively difficult. So there is a risk of overdose because the half-life can be variable, and it should only be given by experienced palliative care specialists. So what are the indications of methadone? This will also be done when you're doing, I think it has already been covered in strong opioids, but it may be a repetition for you. The indications are opioid rotation. It's one of the drugs that you can use. It is relatively inexpensive. When there's true morphine allergy, you may have to give methadone. In neuropathic pain and in renal dysfunction, it is particularly useful. But the contraindications, like I said, when the QTC is prolonged on the ECG, then you should avoid it. Or if there's a history of sudden unexplained death in the family, then there's a no reliable caregiver, or there could be drug-drug interaction with azithromycin, fluconazole, and amitriptyline. So when you convert morphine to methadone. This is a conversion uh, table that you can keep in mind. If the morphine dose is less than 60 mg per day, then the oral morphine equivalent is 2 to 7.5 mg per day of methadone. If it is between 60 to 199, then the OME, then the conversion is 10 milligrams of morphine for 1 milligram of oral methadone. So you divide it by 10. But if the patient is taking more than 200 mg, then the equivalent is equal to divided by 20. Okay. And these are available as 5 mg tablets, and even syrup is available as 5 mg per ml. So, as per expert consensus white paper, the eco-analgesic dose suggested for methadone are very conservative. So, we need not reduce it to account for incomplete cross tolerance. Like I mentioned about how we reduce a drug in patients with well-controlled pain and poorly controlled pain. But in case of switching to methadone, we don't need to do that reduction. Now, buprenorphine can also be used for difficult pain, and it's one of the options for opioid rotation. It can have better pain relief, good tolerability. It can also control breakthrough pain because of its longer duration of action, and it can also be effective in neuropathic pain. It can be given transdermal route, that is Buvelor patches are available, 2.5 mics per hour or 5 mics per hour. Each patch lasts for 7 days. Or sublingual tablets. Last time someone had asked a question. Sublingual buprenorphine is available. Dose is 200 mics. Effect can last for up to 6 hours. And that can also be used for breakthrough pain. Now, having talked about breakthrough pain, I told you this is a little difficult to treat. So what is it? This is an intermittent episode of extreme pain which breaks through the opiate regime that the patient is on. So even before the duration of action of the drug is over, the patient gets the pain. It can occur spontaneously, but mostly it is incident pain that is due to either movement of the affected limb or weight bearing on that, if there's a tumor bearing bone or a spine, then or iliac crest and the patient is standing, then you can have the breakthrough pain. The incidence is pretty high. It can be around 40 to 80%. So we need to know how to handle it. Okay, so the option for a opioid when you're handling breakthrough pain should be a fast-acting, short-duration opioid. So quite often we give morphine itself for treatment of breakthrough pain, but sometimes we may need to give this OTFC, that is oral transmucosal fentanyl citrate or fentanyl lollipop. It's available as 200 mics or 400 mics, and not more than 4 units should be taken a day. It should be sucked over 15 minutes and not chewed, and the effect starts in 30 minutes and lasts for 2 to 3 hours. Now, I had mentioned about this, how we change over to a the drugs. Now we again review the cause of pain. Is it a nociceptive pain, or is it a neuropathic pain, or is there a need for an adjuvant drug to treat this kind of pain? I had already talked about how nociceptive pain is occurring at the peripheral tissue or the nociceptor, which is a nerve ending over here, or the neuropathic pain that is starting right from here, the first order neuron, spinal cord, and brain. So this whole thing is neuropathic pain. Now, ketamine is one option that we can use to treat neuropathic pain. I'd already mentioned where it acts, okay? And this is used as a third line treatment for treating the difficult pain or neuropathic pain. Like I said, it can be given through a variety of routes. And in case of intractable pain, we give what is called a burst ketamine or a pulse course of ketamine for a maximum of 5 days using a syringe pump. So you can start with 100 milligrams per hour, per 24 hours, and give it in a syringe pump for 3 days. If that is not effective, then you can increase it to 300 milligrams in 24 hours. Again, give it for 3 days. And if that is not effective, then you can go to 500 milligrams per 24 hours for 3 days. But if that is also not effective, then we have to stop it. Okay. but this can be used to treat intractable pain. Like I already mentioned this, so I won't go through this, the side effects of ketamine and how do you manage it. Local anesthetics, another important option to treat severe intractable crescendo type of neuropathic pain. Okay. And I've already mentioned how you give it. You can give it both as a local anesthetic infusion, or you can give it as patches, which are available now in India. Okay. And it can also be the other topical drugs that can be given for neuropathic pain are, like I said, capsaicin, but it's not available in India. Topical gabapentin is also available to treat neuropathic pain. The brand name which I use is Arigaba. So if you look at the neuropathic pain ladder, the first line treatment of neuropathic pain is amitriptyline and pregabalin and gabapentin. Okay, that is the antidepressants and the anticonvulsants. SNRI like duloxetine is very good, and a lidocaine patch. The second line of treatment are opioids, especially methadone and even tramadol, because I told you how it acts for neuropathic pain. That is, it acts by activating the descending inhibitory pathway of pain because of its serotonin norepinephrine receptor inhibitor. And then third line treatment are baclofen, mexiletine, capsaicin patch, ketamine, and cannabinoids. So now let's discuss cannabinoids in treatment of these kinds of patients. We know that this has been used for various ailments since ancient times. But in medicine, the use has been restricted because of the legal and social concerns, because of the drug abuse. But a few symptoms in cancer patients can be resistant to the current available options that are available. So, although there is absence of robust clinical data, whether it has really got a favorable risk-benefit ratio, yet people are using cannabinoids in some certain types of cancer pains. Now, a little bit about how it acts. The endocannabinoids act on what is called the CB1 and CB2 receptors in the central nervous system. Now, CB1 receptors are found in the brain, the spinal cord, and the peripheral nerves, but they're poorly expressed in the brain stem, and that is a reason that it has a low incidence of respiratory depression, because we know that the respiratory centers are in the brain. But that is the one that is accounting for the well-known psychotomimetic side effects of cannabinoids. The CB2 receptors are mainly found in the immune system. It has no psychotomimetic effects, and they are now being investigated for its therapeutic effects like its analgesic effect, its anti-inflammatory effect, and its anti-neoplastic effect as well. The two phytocannabinoids that have been extensively studied are the tetrahydrocannabinol, or the THC, and the cannabidiol, which is the CBD. Now, nebiximol or Sativix is an oromucosal spray containing a 1:1 combination of THC and CBD. The THC is a psychoactive component, and the CBD has the anti-inflammatory properties. And they have been found to be well tolerated with improved analgesia in opioid unresponsive cancer patients. Now, if you look at some of the preparations that are available, the THC dominant ones are dronabinol, which is a synthetic THC, and nabilone. Okay. And if you look at the CBD dominant ones available are the CBD oil, which is 99% pure oil, and the dose is given over here. And then you have the combination of the two, which I mentioned earlier, is nabiximol, which is a 1:1 ratio of THC and CBD, and it's available as an oromucosal spray. But remember, these are also Schedule 1 drugs with a high potential for abuse. So the cannabinoids have an analgesic effect, which is comparable to the weak opioids. For example, you see this codeine, 120 mg, is equivalent to 20 milligrams of THC. So it can be used as like I said, the third or the fourth line treatment for neuropathic pain when conventional therapies are failing. The effect usually starts in 3 hours, peak hours, peak effect is in 3 hours and lasts up to 6 hours. So you may have to give it every 6 hours. Now, CBD cannabinoids have also been used for chemotherapy-induced nausea and vomiting. And the ones that are used are the synthetic CBDs like dronabinol and nabilone. I won't go through it because that is beyond the scope of this talk. My talk is on difficult pain, so I'm not talking about chemotherapy-induced nausea and vomiting. So I'll just talk about the side effects of cannabinoids. So they can be classified as neuropsychiatric, it can aggravate pre-existing anxiety, schizophrenia, and depression. There could be impaired cognition, excessive sedation, and impaired motor skills. There's also a risk of infection because it reduces the host response, and there could be cardiovascular side effects. So you need to avoid it in patients with heart disease. So what are the indications of cannabinoids in the current scenario? It is used as a third or the fourth line treatment for neuropathic pain. It can be used for chemotherapy-induced nausea, vomiting. It can be used for cancer anorexia, for HIV-related cachexia, for multiple sclerosis-associated spasticity and pain. It improves mood and has antipsychotic effects. And it has an anti-cancer properties also, particularly that CB2 receptors. And it can also be enhanced sleep, and it can also be given. I don't know about the seizures. I'm sorry, I'll just check that out. So in a recent article that was published, it was shown that medical cannabis has significant improvement in pain measures and a decrease in cancer-related symptoms. Because cancer has a lot of other symptoms as well, like anorexia, mood disturbances, sleep disturbances. So all that can be improved with medical cannabis. And it has also been shown to reduce the consumption of opioid-based analgesics. The side effects were said to be minimal. This was an article which was recently published. But what about its status in India? What is the current status? In many countries abroad, it has been approved for the treatment of neuropathic pain and multiple sclerosis and refractory pain and cancer. In India, there was a petition in the Delhi High Court challenging the provisions of NDPS Act. See, NDPS Act says that cannabis also should not be given, and it is coming under the Schedule 1 drugs. But they say that it should be legalized for medicinal purposes. That was a petition. And the central government has informed the court just this year in January that the use of cannabinoids is allowed for medicinal and scientific use as per law, and it is not completely banned. So that is the current scenario. Now, I already mentioned about the use of corticosteroids. It can be very useful in the treatment of refractory pain, whether it is due to any of these reasons that are listed over here. And the preferred drug is dexamethasone because it has got very potent anti-inflammatory effect with less mineralocorticoid side effects and a long duration of action. And particularly for short-term pain relief, especially those whose life expectancy is less, you can give a course of steroid. Now, GABA2 receptors, I mentioned about the two GABA A, GABA B receptors, right? So GABA A receptor agonists are the benzodiazepines, particularly clonazepam, and GABA B receptor agonist is the baclofen. So baclofen has been found to be effective for refractory neuropathic pain, particularly those associated with spasticity, trigeminal neuralgia, hiccups, and musculoskeletal spasms. Bone pain, another important cause of refractory pain. And it is because of the skeletal related events, and it can be very agonizing and affecting the quality of life. So these are the various drugs that are given for treatment of bone pain. I talked about it in my last class. Now, what is the use of octreotide in treatment of the bowel obstruction? So malignant bowel obstruction in patients with advanced cancer is quite often encountered, particularly when it is an inoperable case. And it's an important cause of refractory pain. And octreotide is a synthetic hormone. It is a somatostatin analog. How does it act? It decreases the splanchnic blood flow, improves the anteportal blood flow, decreases the GI motility, The gastric, pancreatic, and small bowel secretions also decrease and increases water and electrolyte absorption. And that is how it can relieve the intestinal obstruction. How do we give it? It is given in a dose of 300 mics per 24 hours as a continuous infusion for 6 days. The IV subcutaneous bolus can be very painful, so it's given as an infusion. In fact, the MASCC guidelines has said that octreotide is a drug of choice for malignant bowel obstruction. It can be combined with steroids and hyoscine as well. So we discussed about the pharmacological options. Now let's talk about the non-pharmacological options. I talked about this neuropathic pain ladder where there's a step 4 option in which you can use various interventions like nerve blocks and epidurals and neurolytic blocks, etc., to treat those patients who are unresponsive to the third step of the WHO analgesic ladder. So what are the interventions that are available? We have the PCA pump, we have a nerve blocks can be given, or epidural blocks, or peripheral neurolytic procedures like using alcohol and phenol. And you can use intrathecal opioids or even spinal cord stimulation. So these options are considered in patients with severe side effects from drugs whose life expectancy is more than 3 months. There are also central neurodestructive procedures. These are rhizotomy, gangliotomy, chordotomy, myelotomy. So they're all done on the spinal cord and on the brain. Okay. But they are very, very high risk procedures. And the risk-benefit ratio may not be very good. So the risks are outweighing the benefits. It's very rarely done. And only if the life expectancy is less than 3 months, you can consider doing it. I've personally never seen any of these procedures being done for refractory pain. The other non-pharmacological options that are available are dry needling, acupuncture, biofeedback, psychological therapy, physical modality, spiritual therapy, and alternate therapies. So this is a use of dry needling in the treatment of pain, particularly when there is a severe muscle spasm and myofascial pain. And that is not uncommon because when there is a severe pain, invariably the muscles are going into spasm and there is shortening of the muscles. So there could be tender myofascial trigger points in the affected muscles because of the sustained contraction. So how does dry needling act? It acts by reflex relaxation of the muscles and improves the hypoxic local energy crisis that is occurring in the trigger point because of the sustained contraction. And it also releases the trapped inflammatory mediators that are there in these trigger points. The other physical therapies are all listed over here. These are some of the therapies that can be used. It's not single therapy, but it is like a multimodal therapy. In addition to this, you can also use this, okay? Standalone, it may not be effective, but it can be used to enhance the effect. How do these physical therapies act? You remember I mentioned about the gate control theory. So the physical therapies are also acting in a way to close the gate so that the pain impulses are not going up into the central nervous system. So anti-anxiety medicines, sleep, all these things, relaxation, meditation, and these kind of therapies, massage, heat, cold, all are acting by closing the gate and preventing the pain impulses from going upwards. These are all the problems that can happen in patients with refractory pain. Fear, anxiety, depression, anger, guilt, financial issues, fear of the future, concern about loved ones, loss of role or role reversal, and even questioning God. So you can treat it with a variety of psychosocial therapies, which are some of them are listed over here. So let's come back to our case scenario. Now, this patient had pain that was unresponsive to the step 3 drugs that we were giving, that is oral transdermal patch, right? So what were the reasons, possible reasons? The medical reasons were, could there have been a progression of disease? And the colostomy that he had, the site definitely looked unhealthy. Or is there a failed route of absorption? In this case, it was a transdermal fentanyl. Was it not getting absorbed, or were there other psychosocial concerns? Now, what did we do? We admitted the patient to the hospital. We found that the colostomy was non-functional. In fact, it was necrotic. So that was the cause of the very severe pain that this patient was having. And so what was done was a root conversion was done. The fentanyl infusion was started with supportive care. The pain subsided gradually and end-of-life care was instituted. This was explained to his relatives and he expired free of pain 2 weeks later. Now, in this particular case, were we being too drug-centered or intervention-centered in our approach? What were the non-pharmacological interventions that we could have done for this patient? Now, let's talk about the psychosocial concerns. He was a highly educated retired doctor. He had no financial concerns because the entire cost of medical treatment was reimbursed. He had a supportive family, a caring wife and daughter. The wife was the main caregiver and she had taken on the role of the head of the family, managing all the medical, the financial and the household, everything she was managing. But this gentleman was depressed because he knew that there was no cure for his disease and he would not live long. So there was a sense of hopelessness, helplessness, and powerlessness. He also experienced loneliness and isolation. He had withdrawn from friends and relatives for 2 years. You remember that it was COVID times, and that had added to the isolation as well. In addition to the cancer, he did not want to meet anybody. He had a low self-esteem. He was totally dependent on his wife, even for his self-care activities. He was also having guilt because his family had given up all their activities and wife had given up her job also so that she could be his full-time caregiver. And there was a role reversal. He was the head of the family, but now his wife had taken over all his responsibilities and he felt helpless and powerless. So these were some of the psychosocial concerns that this gentleman had. So if you look at again the analgesic way we can treat this patient is the analgesic ladder, step 1, step 2, step 3. And then if it is not responding to that, then we can go in for some non-pharmacological options like intrathecal opioids and all that I mentioned, or you can go for neurodestructive procedures. But at the same time, at every step of the ladder, we need to address the psychosocial concerns as well. So if everything fails, then we need to consider palliative sedation. We may have to accept failure, but we should never desert the patient. We should be fellow travelers in their difficult journey. But even if we have failed, we should convey that with sensitivity. And we should continue with the psychosocial spiritual support and treat any worsening of the condition. Can I stop the screen share?
Yes, ma'am.
Okay.
Thank you so much, madam. You have discussed everything in detail. I hope it's clear for everyone. Madam has described everything in detail, starting from assessing the cause of pain, and then we have to ensure the proper drug complaints, and we have to identify any correctable causes for pain management, and importance of multimodal approach, both pharmacological as well as non-pharmacological. And we will share the presentation with you all so that you can revise. And I know you all have some doubts. First, we can move on to the case discussion by Dr. Priya, and after that, we can have case discussion with Madam. And you can unmute and ask your doubts that time. Madam, is that okay, Madam?
Yeah, fine.
Okay. Thank you, ma'am. Thank you so much. Welcome, Dr. Priya.
Yes, ma'am.
Over to Dr. Priya. You can introduce and just start case presentation.
Good evening, everyone. I am Dr. Priya, anesthesiologist and pain physician in Manipal Hospital, Hebbal. So this was one of the scenarios. This is a 42-year-old patient who presented to our hospital with carcinoma rectum. The patient complained of pain in the perianal region since the past 6 months. The patient was diagnosed as a known case of carcinoma rectum after being thoroughly investigated for weight loss and blood in the stool 7 months back. Post this, patient was started on 4 cycles of chemotherapy and 25 cycles of radiotherapy. Now he complains of pain around the anal region, which started 6 months back. Now the perianal pain has increased since the past 1 week. The pain is aggravated on sitting and on defecation. Pain is of burning type. The patient complained of NRS of 8 to 9. He also suffers from constipation on and off. On examination, patient was conscious oriented. Temperature was normal, pulse rate was 90, respiratory rate was 20, blood pressure was normal, and systemic examination was unremarkable. On evaluation, patient was previously on intravenous tramadol and oral tramadol tablets, and was also taking paracetamol, both oral and intravenous form. And he had been tried on buprenorphine patches, but patient had no pain relief. Investigations were found to be normal, within normal limits, and LFT was also found to be normal. Patient's colonoscopy report showed that he had a hemicircumferential growth, which was extending up to 10 centimeter from the anal verge. Sigmoid descending and ascending colon were normal. Biopsy of the tumor was done, which showed a feature suggestive of adenocarcinoma rectum. On CT scan, there was irregular heterogeneously enhancing lesion in the rectum. It is infiltrating the adjacent mesorectum, mesorectal fascia, and extending up to the presacral area. The anteroposterior diameter was 2.7 centimeters, and mesorectal soft tissue extension was 13 into 6.7 centimeters in the presacral area. There were multiple enlarged lymph nodes, which were seen in the para-aortic region, the largest measuring 2.1 into 1.4 centimeters. Now, considering the psychosocial aspects, the patient is a 42-year-old married man with a 6-year-old child. He lives in a joint family with elderly parents and a younger brother. Patient used to be a manual laborer, but currently he is unable to go for work. Brother is the only earning member of the family now. He also has multiple loans and has borrowed money for his treatment. Patient also worries about returning it. Patient is extremely embarrassed about the location of the tumor and is reluctant to talk or discuss about the illness or pain. He has bouts of anger and mood swings and generally shows it to his wife. He has isolated himself from friends and relatives. He also worries that surgery was not done to remove the tumor. At present, patient is on tablet paracetamol 650 milligram 3 times a day. He is not taking it regularly, and also on Ultracet, which he takes twice a day. In the past, patient was on tramadol injections, paracetamol intravenous injections, and buprenorphine patches, which did not give him much relief. He takes Dufalac syrup when he feels constipated, is also on ranitidine and multivitamins. And the main concerns in this patient are, the most important is pain. He is not getting relief in spite of taking multiple analgesics. The quality of pain has changed since the past 15 days. He experiences burning pain that has increased significantly. He also faces financial issues and is unable to discuss about his illness with others. So this is a 42-year-old man with carcinoma rectum with severe pain around perianal region with financial and psychosocial problems. The discussion points would be, does this patient need palliative care? Do all cancer pains need morphine? How will multimodal analgesia help in this scenario? What is the role of interventions in cancer pain management? Can he be helped with better communication about the pain?
Thank you, Dr. Priya. Now, the discussion is open to you all. First discussion point is, does this patient need any palliative care? Any one of you can unmute and answer. We can make it interactive so that
Good evening. Yes, this patient will definitely need palliative care because there are different aspects of his condition that need to be managed. One is, of course, the pain. Secondly, the treatment, how he would like to, understand the treatment, what he would like for the future, and as well as the psychosocial issues that he is facing because of his condition. So palliation would definitely help him overcome all of those things.
Thank you, doctor. Any other points?
Good evening, everyone. According to myself, Dr. Rahul, according to me, this patient has undergone definitive chemoradiation. So, according to me, the pain can be due to post-radiation changes. So, local area should be examined. It could be because of ulceration formed due to post-RT changes. It can be managed with local application of gentian wallet and Anobliss. And yes, as we have discussed earlier also that palliative care and definitive treatment should go on head to head. So yes, this patient is of palliative care, but according to me, local examination is more important.
Thank you, Dr. Rahul. Yes, as you have already mentioned, this patient definitely needs palliative care. He is in pain and that to be managed. And he has, apart from the physical pain, he has emotional, psychosocial issues, everything. And you already mentioned, and it's true, the palliative care should start from this time of diagnosis and it should go hand in hand. And I think it's clear for all of you. Any doubt on this point?
Can I just ask a question? I just wanted to know, he had this gentleman had a query that why was surgery not done? So he did undergo radiation and chemotherapy, but is there any particular reason why surgery was not done?
From what I gained from the history, they were planning for a chemo radiation for destaging the tumor or bringing the size of the tumor down and then planning for a surgery later on.
Yeah.
But there was a gap in communication between the surgeons and the patient. Probably they have spoken to the relatives, but the patient always had this doubt that tumor is still there and it is probably growing. So there was a communication lag there. Also, the patient was not coming out with his queries because he was extremely shy of asking questions about his and the area, showing the area or describing the pain. So this was one thing which I felt that probably the treatment plan should have been discussed with the patient in detail.
Yes.
Sorry to interrupt, ma'am. Maybe this patient is of locally advanced carcinoma rectum and treatment is initial is a neoadjuvant chemoradiation. And then we wait for 6 to 8 weeks, then we go for surgery. So maybe he is locally advanced and planned for surgery later.
Because these concerns, the doubts that the patient has are also to be addressed. Okay. So maybe someone can just tell him that these were the reasons or whatever, because see, these doubts are the one that niggle him and cause a lot of distress, that maybe I should have had it and all that, that kind of a thing. The other thing is like, according to me, I find that he's having very severe pain. Okay, it's 8 to 9. So definitely he needs to move beyond the step 2 and go on to step 3 drugs. And the most inexpensive option that we have available is morphine, right? Even these patches are so expensive, buprenorphine and fentanyl. So, and considering that he has got financial concerns, I think he's a candidate for a strong opioid, which has to be given according to the regime that it is. That is, we have to follow strictly the WHO analgesic ladder is by the clock. It has been given every 4 hours. And then because of the radiation that has taken place, I've seen a lot of people who go into post-radiation neuropathy. So he had a burning sensation. So that could be a new onset neuropathic pain. So then he will need to have the adjuvant drug as well, like gabapentin or pregabalin or an antidepressant drug, depending upon the You can start with low doses and go up, and that could also help in this patient. Along with the strong opioids, you may have to add a neuropathic agent also, because that pain is a burning pain. And then non-pharmacological modalities. If he's having difficulty sitting, are we providing something for him to sit on that is taking the weight of the area, like some soft ring cushion or something like that, which will not put pressure on that area, because, neuropathic pain, even touch can cause pain. Allodynia, hyperalgesia, all that is there in neuropathic pain. So we need to find some ways in which that this kind of pressure is not there on that local area. And also the stools, he's having constipation on and off. So we have to ensure that he's getting a proper laxative, you see, and the stools are not hard. And these are some of the modalities, but of course, you can even go up to the fourth step of the ladder and maybe give an interventional neurolytic block, like superior hypogastric block, which will cause analgesia to the area of the perineum and rectum and all that thing. That is one option that can be thought of. But a very important thing is to address his psychosocial concerns. He's got a lot of it. And it is manifesting as shame. It is manifesting as guilt. It's manifesting as anger and depression and maybe insomnia. So like in that patient, I told about all the concerns that gentleman had. One by one, we need to do it and then try to address them as well. So this is what I feel is the way forward. But any other inputs from anybody else?
Ma'am, there is one query. As patient is having a problem in passing stool, if we give him morphine, it also causes, ma'am, constipation. So will it be beneficial to add morphine in such patient?
See, we have to give the laxative along with morphine. See, even in CA rectum patients, we can give morphine, but the laxative has to be given particularly along with it. Because it is, you have to give a stimulant laxative, because morphine is causing it is relaxing the gut, right? So you need to give a stimulant laxative. So I don't think it's a contraindication for morphine. Having CA rectum is, I don't think it's a contraindication, provided you give the laxative along. The hand that writes the morphine, that same hand should simultaneously write a laxative as well.
Yes.
Otherwise, your prescription is incomplete. You have to give a stool softener as well as a stimulant laxative.
Ma'am, would you also require an anesthetic because of its neuropathic pain? And it's CA rectum, something, for
Yes,
the
yes. Yeah,
lower area?
you can give local anesthetics in that area. Local anesthetic gels and creams can also be beneficial in this gentleman. Like I said, these are all the number of options that you can add on. You see, it's like nothing is, there's no single bullet, magic bullet is not there. You have to add on all the multimodal, whatever you can think of. All the non-pharmacological options also you should think of.
Ma'am, topical gabapentin is available in India?
Yes, yes, yes. It's available. Many names are there. One is Arigaba, Arigaba. So that is one thing that's available. But if you look up on the Google, you'll find other options also of gabapentin.
Ma'am, is it applicable here?
Yes, yes, you can try that because there is a burning sensation. It could help externally. Okay, you can give it externally, and maybe at the anal verge you can give it because gabapentin is being given orally, but then there may be certain additives in that which may not be systemic absorption shouldn't take place, but definitely at the anal verge you can give it.
Thank you, ma'am.
Any other inputs from anybody else?
Ma'am, tablet methadone is available in India.
Yes, yes.
What is the
It's
trade
available.
name?
Tablet methadone, I think it's available as methadone tablets. I'm not sure of the trade name. It's available,
Okay.
but it is available only in certain places and certain centers. It's not available freely. Okay. But there are certain palliative care institutes that are using methadone. But like I said, it should be used only when you are very familiar with the use of opioids, strong opioids. Only then we must go because of the potential side effects with methadone. Otherwise, it's a very inexpensive drug. Like morphine, it is very inexpensive. But the availability may not be that free.
Okay, ma'am. Thank you, ma'am.
Madam has discussed all the discussion points. Do all cancer pains need morphine? Do all cancer pains need morphine? I would like to hear from you, or please unmute and answer.
Can
So
someone answer that question, please?
Yes, good evening. My name is Dr. Suchitra. So again, it's the use of the WHO pain ladder. So we need to understand the need of the patient and work with their understanding and their relief with the agents that we're using, and then decide whether morphine is what is required eventually.
Correct. It all depends upon the step of the WHO analgesic ladder. Or the intensity of pain. Basically, the criteria for using these drugs are the intensity of pain on an NRS score.
yes, as Madam has said, all cancer patients may not need morphine. Sometimes with tramadol or weak opioids, the pain may settle. If we always go with WHO analgesic ladder. Okay. And how will multimodal analgesia help in this scenario that has already discussed by Madam? And any other doubt in that? Anyone have any other doubt? I hope it's clear for you all. A role of interventions already mentioned. And last discussion point is, can he be helped with better communication about the pain? That is also already mentioned. Anybody can unmute and answer.
Yes, if the communication was better, a lot of issues would have been solved. As Dr. Priya mentioned, that there seemed to be a lag in the communication, that the further intervention could be required after the chemoradiation, but that's something the patient did not understand completely. So maybe at that point, if there was a multidisciplinary team handling his case with some amount of palliative care, the patient could have asked more questions and understood what the future treatment would be, and maybe he would be a little clearer on what his next steps needed to be.
Because we must remember that this gentleman was a laborer, manual laborer, right? So his education may not be that good, his literacy level may not be that good, but it is so important that the doctors convey it according to his level of intelligence and literacy, you see. He's not the kind of person who will look up the net and find out the options or do doctor shopping and things like that. So it was very important that the doctors explain in very simple terms what he required, considering his socio-economic status.
Thank you, Dr. Sujitra. Thank you, Madam.
Ma'am, one quick question, ma'am.
Yes.
Whether ganglion impar has any role in this scenario?
Yes, you can try a ganglion impart block because that can cause relief to that. Yeah, that's a very good thing, Along with the superior hypogastric, that is a little more interventional. Ganglion impar is a little bit, more easier to do. It could help. You could try it out. Definitely, you could try it out. Yeah. And the way to go about it is first do a diagnostic block. And if that works, then you can go ahead with a neurologic block.
Okay, ma'am. Thank you, ma'am. Thank
So for the benefit of the audience, do you want to tell what is a ganglion impar in case somebody is not familiar with it? Dr. Mishra, would you like to explain what a ganglion impar block is?
Particularly a sympathetic block which we give particularly in cases of coccydynia also.
Yes.
And particularly when we are not well versed with the superior hypogastric plexus block,
Exactly.
particularly pelvic pain, to some extent it works. To some extent it
Yes.
works.
The ganglion impar is at the level of the coccyx, right? I think
Yes,
C2
ma'am.
or coccyx 2 or 3 or something like that. You can see it and you can give a dye and then inject it through the coccyx. See,
Yes.
fluoroscopy guided injection, correct.
Yes.
That is one good option you can think about.
Thank you, Dr. Mishra. Thank you, madam. And we have few questions in the chat box. Actually, it was already discussed by madam in the presentation as well as in the session. Is there availability of cannabinoids in India and its brand name?
Yes, it is available. It's available in India and it's available as CBD oil and even THC is available. Brand name, I mentioned the brand names in the presentation, but it is definitely available and there are doctors who will, like I don't know how to give it, but if you locate the company, then they have their own doctor on board who will guide the patient as to how to take it. So CBD oil and as well as a tablet, and I don't know about the oromucosal spray, but the other two options are available in India.
Thank you, ma'am. Another question is, please explain about intrathecal phenol intervention for cancer rectum, CA rectum. Intrathecal phenol intervention for CA rectum, madam.
I don't know. I'm sorry. I don't know what intrathecal phenol. Can anyone enlighten on that? I have not done it. I've not seen it, and I didn't know about it. I would be very, very scared to give intrathecal phenol. I would never do it.
Okay, ma'am.
So maybe someone can
Yes.
find out that and let us know whether
Yes.
how effective it is. What are the risk-benefit ratio? Any intervention that you do, like you have so many central neurodestructive procedures, but the risk may be more than the benefit, right? And it is only for terminal patients who do not have more than 3 months to live. But so that has to be definitely kept in mind when you think about all these very highly interventional procedures.
Dr. Manoj Shinde has asked this question. Doctor, do you have any few points to add on this? Do you have any previous idea on this?
No, I just read about it. One of the intervention for the to manage this difficult CA rectum pain. I do not have any experience about it.
Okay. Anyway, we will try to deal with it. Okay, doctor, we will inform you all. Okay, on this before the next session. Okay. And next question is about the intervention, madam. Ganglionic impar, that is already explained. Superior hypogastric block and ganglionic impar will help him like that way.
Yes.
Good evening, ma'am. I wanted to just take us back a bit regarding the prescription of opioids. In one of the previous sessions, it was mentioned that everyone cannot prescribe opioids. Is that something that you decide based on your own understanding of the opioids, or is there a specific person you need to refer the patient to? In case you need, stepping up of pain management, like at step 2, as a family physician, if I'm able to manage it up till step 2, but my patient requires a step up in pain management, who do I ask him to meet if I can't prescribe the opioids?
See, you are qualified physician, right? And you have done a palliative care course. So there's no reason why you can't write the drug, write the prescription for opioid. It's just that you should be familiar with it, and that you're getting done by going through a course like this, right? The idea of doing these courses are that it enables you, empowers you to take the for the to give these kind of prescriptions. So once you know about all about the drug, it's how you give it, its mode of administration, the side effects you have to watch, and the various restrictions associated with it, then there's no reason why you can't prescribe it. You have to do it on a particular form, that DD-12 form, with a stamp and your all your details also. So there is the idea of doing all this is that it's empowering you to do that. You don't have to refer to a particular doctor. At the end of it, you are becoming a palliative care physician, right? So I don't think there's any restriction for you. But like I said, we should be thoroughly well versed with the pharmacology, the pharmacodynamics, and the kinetics of the drug and the side effects, everything, before you write all these things. And definitely, you should start off with morphine and move on to methadone only when you're very comfortable using these drugs.
Thank you, ma'am.
Good evening, ma'am.
Yes.
Ma'am, I wanted to ask, for how long can we use this medical cannabis, and can it be used in end of life care also?
I think it can be used in end of life care. And see, medical cannabis, after all, these patients, many of them have got limited life expectancy, right? It may be 3 months, 6 months. So there are people who are using even cannabis for getting sleep. There's a patient who's of mine, who's a non-cancer patient. She's using CBD oil for sleep. Maybe in a very low dose, but she's using it, and she's a very intelligent lady, She would not be using it otherwise, So there is no harm in using it, provided it is given in that prescribed thing, and provided it is not having the side effects. Like, for example, CBD has got less of the psychotomimetic effects as compared to THC. So maybe CBD can be used for longer, and THC is given only when there is other issues also, like mood changes and things like that. So CBD doesn't have much of the psychoactive component in it. It doesn't have, in fact.
In many cases, I have seen, like, in practically patients having anorexia, those who are not able to eat also, right, for a longer period of time. So it's like basically they are basically fastening their time to go, basically.
Is it cancer patients you're talking about?
Yes, ma'am. In cancer patients, those who are suffering from anorexia, also having symptoms of anorexia, so it could be used even in the end of life.
Yes. Cancer anorexia is mentioned as one of the indications.
Sure. Thank you.
Dr. Pranav, thank you, madam. Madam, we have already. Okay.
One question, ma'am.
Okay.
When we are going to start morphine in a patient with severe pain, is it always required to give the morphine tablet 4 hourly? Most of the times we start 6 hourly and patient's pain is under control.
Ideally, you should give it 4 hourly. You should, but if you feel the patient's pain is under control with 6 hours, then you go by 6 hours. Maybe it's a patient, they're poor metabolizers, maybe, That is why it is taking, the duration of effect is longer. Or maybe it's an elderly person. These are the people in which you can increase the duration of action. But like I said, there's the main rule is 4 hourly. But ultimately, it's a patient that tells you how often you have to give it. And if the patient is getting good relief at 6 hours, then why do you want to give it every 4 hours? It's like a full petrol tank and you're adding more petrol to it. Okay, there's no need to do that. So if you feel there are, I think, poor metabolizers also, maybe that is one of the causes why he's having a longer duration of action. But the textbook description is that its duration of action is 4 hours and it has to give 4 hours. But ultimately, it's a patient who's guiding you also.
Okay, ma'am.
Thank you, Dr. Mishra. Thank you, madam. Madam, We have another question in the chat box. Any brand name of oral ketamine?
I don't think there's a brand name for oral ketamine. Ketamine tablets are available, but I don't know any
Okay.
brand.
With this, we have completed all the questions in the chat box, madam. Any other doubts? Actually, madam has described everything in detail from the first to the last, and discussion points also, madam has described everything.
And I think it was a very good case presentation in which we highlighted all the aspects of total pain management, in which it was not just a physical pain, but there was a lot of psychological, social, and possibly even spiritual aspects, although that it was not highlighted. But maybe he would have even questioned, God, and felt that this is a penance for what I have done in the past, that I'm suffering from pain and things like that. But it sort of encompassed all the various aspects of cancer pain. And I think there was a very good discussion also. And but like I said, difficult pain is really difficult to treat. Okay, so we need to do like I said, a comprehensive pain assessment, reassessment. Like in this gentleman, it's possible that the burning pain started recently. So then we have to add the neuropathic drug also. So there is a constipation issue, there are anxiety issues. So how we have to add the various adjuvants, and then after that, we need to make sure that are we using the pharmacological options and the non-pharmacological options in a very comprehensive way to treat him. And very important is the never lose a patient connect. Never look at the disease, but look at the person. Okay, what is that person going through? That is called empathy, right? You have to empathize with that patient. He's a young boy. I mean, I would call him a boy, 42-year-old, with a 6-year-old child, with financial issues, with a lot of psychological issues like the location of the tumor, the questions he has for the doctors. So a whole lot of psychosocial issues are there. So that needs to be handled very sensitively. It's not possible for the doctors to do it, but if there's a psychosocial worker, they would. Doctors don't have any time to address many of these issues.
Yes, madam. Yes. Madam, we have another question in the chat box. That is how to treat nausea and hallucination during ketamine therapy.
Okay. During ketamine therapy, you can give a psychotomimetic agent like a benzodiazepine. So whenever you're giving ketamine, invariably we should give benzodiazepine. The commonly used one is midazolam. Okay. And we can also combine it with an ondansetron for treating the nausea vomit. But midazolam is what we give for the psychotomimetic, preventing the hallucinations.
Thank you, madam. Madam, another question in chat box. Ma'am, can you please suggest what can be given for anorexia in cancer patients apart from cannabinoids?
See, we have to find out about, talk about the nutrition and the diet that this patient is taking. Invariably, I found that they have a sensation of bloating, nausea, vomiting, and, the nausea feeling and sensation of fullness, which is because of the impaired bowel movement. So very often we find that even drugs like metoclopramide are not prescribed. So I always start off with giving something that enhances the forward movement of the gut. That itself can, to a certain extent, improve the feeling that less of fullness, I'll be able to eat something. Okay, so if the patient is not on metoclopramide, I would suggest that be added. And then they have to explain about the kind of food and how often he has to take it and how much amount he has to take it. So we have to explain that never take small frequent meals. Instead of 3 meals, make it 5. divided every 4 hours, a very small meal. That is more difficult to it's more easy to handle than taking a large meal. So these are the things that we have to actually ask them. What are you eating and what exactly are you feeling? Why? Because anorexia will be there because that is part of the disease, you know. But how we can handle it all depends upon the questions that you're asking the patient. What is he eating? How much is he eating? How often is he eating? And are we giving any prokinetics? Well, these are the things that we can help to a certain extent to increase his food intake. But I certainly would not advise any drugs other than cannabinoids for anorexia.
And another question is, how long that interventions help the patient to be pain-free? Are you doing alcohol neurolysis or just steroid and local anesthesia?
See, initially we start off with a diagnostic block by giving a local anesthetic with steroid. So if that is effective, then you can move on to a neurolytic block with alcohol or phenol. Normally, that's supposed to last, but then you can never say how long it will last. But if it is effective once, I don't know whether it can be repeated, but definitely that, you know, after all, these patients, many of them, their life expectancies may not be much. And quite often that if one block is effective, it will generally be effective for them. But alcohol with the steroid injection does not last long. It may last only for maybe a month or so, or 2 months.
Thank you, madam. Thank you for your patience, for explaining everything in detail. And thank you everyone for making this session very interactive and knowledgeable.
I think there's one last question in the chat box, is that
Yes,
if the
again.
patient is sedated with morphine, then what do you do? So that is one of the indications that you should not escalate morphine, but you have to de-escalate the morphine dose. Sedation is one of the effects that you're looking for. It could be a sign of neurotoxicity, the early sign of neurotoxicity. So at that point, you have to bring down the dose of morphine that you give.
Yes. With this, we are finishing the discussion for today. Thank you so much, madam. Once again, thank you so much for you have explained everything in detail, and thank you for your time and patience for explaining everything in detail, madam. Thank you so much, and thank you all. And over to you, Sweetpriya.
Thank you, Dr. Mary Abraham. As I said earlier also, there is a minimum guarantee which we could have in your sessions, like one of the most informative and interactive sessions. Thank you so much. And we do look forward to having much more sessions with you in future as well. Thank you so much. And thank you participants, each and everyone, for making this session interactive, because it is the interaction that makes the faculty also interested. That is what makes them curious. And thank you for making all these sessions so much interactive. And hoping to see you in the next session with another interesting topic and eminent faculty. This is Sweetpriya, along with Dr. Mary Abraham and Dr. Grishma Nair, signing off from the Tips Eco Hub. See you in the next session. Till then, everyone, take care. Bye-bye.